all do. Let me see if I could start with by sharing the screen. Let's see. I think that
you should be able to.
Can you see it?
Not yet. It should be a thing in the middle. Oh, there you go.
All right.
Okay, we see it.
Okay. Well, I start by welcome everyone to the 11th Cohen syndrome family gathering. You know, this does move the slide? No. Does slide move?
Are you doing a PowerPoint?
Yes, I am.
Yeah, so look on the bottom of your screen. That's where I was struggling with. See if there's like an arrow or something for your slide.
Okay.
I know the PowerPoints are kind of.
I got it.
Okay.
Yeah, thank you for that, Lisa. You did a great job to summarize history, Cohen syndrome family association. You know, and also I want to also add a little bit of information about the gathering. You know, we almost 20 years ago we have this. We started this gathering. And we are, you know, I'm a physician. I'm also doing the research scientist. So I'm a former believer, you know, that to serve better those children with special needs, with a genetic condition, we have to do everything we could, you know, and also to create the opportunity periodically for the physician and for the research scientist and for the family to meet each other. You know, I always feel inspired by the family. Every time when we had a meeting, they always raise the new question, new challenges, and we always feel we learn something from them. I think that to some degree, families feel the same way. They feel, you know, there is disease, you know, like a Cohen, which is so rare. But then there's people, the doctors and research scientists, they really care about it. And they take a great interest, you know, personally, scientifically. They want to do something about this disease. So I feel, you know, that's actually how the meeting we started almost 20 years ago after we identified the Cohen syndrome in our community. You know, we feel this family gathering, you know, as we have today, is a time for sharing, for learning, for everyone, for the families, for us as a doctor, as a research scientist, and we get inspiration, encouragement, and challenge from the meeting. That's actually how the meeting started. I believe that the picture here on my screen is actually the last meeting we had in person. You know, I'm so excited, Lisa, you say we're gonna have the meeting in person again. We need to, it's different, you know, than I know when we have a meeting in person, we can give a hug. We can hug those children, and then with virtual, we just cannot do the hugging. So that's something, you know, very personal. It's different, and I think that also our local families, Amish family, they don't get used to use this virtual, you know. So to have the meeting in person will be great. We're looking forward to the next meeting. And here I want to particularly thank the people here. You know, those you know, this is probably the picture was taken almost 10 years ago. You know, when just like Lisa highlighted, you know, that was about 15, 20 years ago when we, after many several years, we had constant gatherings. We feel it would be better have a family, parents to lead this organization instead of us to do. This very much more make more sense as a joint effort. And I'm very grateful for those families, the parents, they come out, stand out, take the leadership. Particularly, I know that Lisa, you have served the president and for more than a decade. To not only take care of your own child, with Cohen syndrome, but also you help other families. Diane, the Joanna and Beth. I know the Ashley. We just met each other in person about 3 weeks ago in California. So what you do, the work you do to help other families, is beyond what you think. It's really we're really grateful for the society, for this constant circle. You take leadership and to help other families. And then I think that from 15, 20 some years ago, about 15 years ago, we have constant association until today. What you have accomplished is amazing. I want to thank each of you, and then you do this as a volunteer, but you're doing this well. Thank you very much. Because I want to, just like Lisa say, just think about that. We just had a Mother's Day a few weeks ago. We'll have Father's Day in a couple of weeks. I think that I want to think a little bit differently here. That those children with the Cohen, they're bound and to the families, to the you guys, as a mother and as a father, the children change the family life, many different ways. They are special, but they come to the family for a reason, and then they help. I mean, they give us a lot of things to think, and then we do things differently because of that. And then we have the clinic here, DDC clinic here. It is our privilege, to be included to your journey, to love those children and to care those children and to do whatever it takes to help those children and to maximize their potential. And then, we actually, our clinic just celebrated our 20 year. So we actually just published this book. This is actually a cover page of the book, Our Journey of the Hope of Healing. It is a journey. We have privilege to work with you as parents together to, the journey of with hope, with healing, with the compassionate care we could provide. We're very grateful to be part of the journey you walk through, and then we'll continue, hopefully, to help those children, in years to come. I want to take this opportunity to tell a little bit of story about our clinic. A few slides, just kind of share a little bit of our journey. Is some story I shared that before. If this is not the first time you are in the meeting, you probably heard a part of this story. Our clinic started about almost let's say by today will be 20 years. So last year was our celebration of 20 years. So it's interesting. It's actually started by the family too. We local Amish family, 5 families. Each family has one child or multiple children with special needs. Those children actually have been seen by by local medical center, Cleveland Clinic, University Hospital, and then Pittsburgh Medical Center, and then Cincinnati, Columbus. But nobody could give answer. So those family decided to travel to the clinic in Pennsylvania to see the country doctor, Dr. Morton. Maybe he was working with, he has been working with children, Amish children with special needs help a lot of families. So that maybe they could help family here. So after 6 hours, they actually went to Lancaster, Pennsylvania. I saw Dr. Morden, and Dr. Morden closed his clinic for 2 days just for these 5 children. But towards the end of the 2 days, he said, well, this disease is different. We don't know much, about it. But then I know the answer. Answer probably is you guys have your own clinic in Georgia, Middlefield. So that's actually how the clinic started. These 5 families travel back and they got excited about it. And then when they got home, they said, well, let's have a meeting to see what we could do. So this is actually the Amish has passed around in the Amish kitchen, that they raised $50, 5 families. Actually, that was how the clinic started 25 years ago. So this, this is as you all know, those children with special needs, they're special. They also need a special care. They deserve special care. They need it. So these family, they actually get together. They feel, okay, well, what kind of the clinic? If we have our own clinic, what kind of clinic we're gonna, we like to have? This sounds like a dream. It's a 5 family with $50 start a clinic, but it is a dream. But the dream they like to have the clinic is a gathering place, is a place with love, compassion, and caring, and the children and family are respected. A place people take time to listen and sharing, and then I hope that's what we're doing today is take time to listen and sharing, but also is a place of the faith and hope, and then that is important. We feel that's important. That's what we do. We try to keep that in mind every day for the work we do. Is always the place. We want to be the place with hope. So to some degree, this the clinic of the future in the New York Times front page, to some degree, they feel the clinic we established, the center we established, is not only just for them. They feel maybe it's too late for them, but if we can, help other through this center, we'll be glad to do it. And then to some degree, that is an inspiration our founder give to us. Not only help the people locally, the children, but also help the people wherever we could help with. So this indeed, currently our patients come from 37 different states, from Canada, from Australia, from New Zealand, from Europe, from Asia. And I know today our audience also, we have Cohen syndrome from different places. I'm glad, Lisa, you have a translator set up with different language. And this is it is a disease, always we keep in mind, this is not an Amish disease. It is a disease could impact everyone, any family. So, that's important. We do have a lot of patients, constant patients come to our small clinic from long way, travel 100 miles, thousands of miles, come to our clinic. And we're glad that we can help them to some degree. And we believe research. We believe research. We believe that research is something it makes difference. They will give us answer for the diagnosis. They will also give us the answer for the treatment, and then they could potentially change the outcome. That's why we're so into the research. For the last 20 years, we have our clinic has published over 80 publications and in the nature science, describe different diseases. It's interesting. If we go back to about this story we tell about these 5 families, they travel to Lancaster, Pennsylvania. Those 5 families actually, after 20 years, each family has answer, and they know exactly disease. And then at least 2 or 3 conditions, they're very treatable. To some degree, they fulfill their mission by finding an answer to have this clinic. But I think what they didn't realize, our founder, is those 5 different conditions. The condition also help the many other people, particularly our research work. And then among these 5 families, they travel to Pennsylvania. 1 family actually affected by Cohen syndrome. So this is something, they make, actually, my very first patient here in Ohio actually was Cohen syndrome. I spent 2 days for my first Cohen syndrome patient. I spent 2 days to see just 1 patient, just because I collected all the medical information, trying to learn for the 1 day. I did a house call, but I didn't feel I understand everything. I went back next day, spent another day. So actually, I don't know if the parents are here today on Zoom, but she knows how much time we're trying to learn this disease. So this is a slide I don't need to tell you guys. Actually, you actually know more than I do about the Cohen syndrome. But I thought it would be still a good idea to highlight a little bit, the information. The Cohen syndrome, we already know was first described by Dr. Michael Cohen in 1968. We recently, the Dr. Cohen passed away recently. I want to honor him with this talk too, for his work and also his service to the Cohen syndrome families. So far we don't have exact number about how many Cohen syndrome patients but we believe it's probably about 1,000 or 2,000 minimally. But we know it's underdiagnosed. But in the medical literature, we probably have 250 reported in the medical literature. Our clinic currently see over 100 patients with Cohen syndrome. I would say half of them Amish and half of them non-Amish. So the many medical challenges, we face, family face, for example, like frequent ear infection, pneumonia, and also the big problem when you're getting older is vision problem. So that's what we deal every day. And I know we have a speaker today to address that issue. But those people, these children, they're fun to work with. I have to say, I get more hugs from those children than get from my wife, maybe. So they are very, they really, they're really fun to work with. They have cheerful personality, and then they have great hearing, incredible memory. A lot of things we know. This the incredible children, and then a lot of them know adult, but we really enjoy work with them. I want to, let's see, I want to show you a little bit, this is my family connection with Cohen syndrome. You see this picture in the first slide, the previous slide in our clinic 20-year celebration book. This on our cover because Cohen syndrome is important. But this is Alan. He actually this is picture was taken in previous Cohen syndrome gathering. There was a best buddy, that we talk about doing one Cohen syndrome gathering, and then Alan and with his best buddy. So the best buddy was actually a program, the college student, connected with children with special needs, become one pair best buddy to a great support system. And then there was a one time there was a discussed and presented during the gathering, and then it happened. My young daughter was in that meeting, and then she was about to go to the college, and then she thought it was great, and then she went to the college, but then the college she went didn't have this best body, so she started and she served as the president, and then to start this to work on her college through her college for 4 years as and then she picked up the person who take over her position after when she graduated, and then to start the program in her school in Vandenberg. This is her and with her best buddy. So no, she's actually she just finished last year, graduated from medical school. She's a Dr. Wang Jr. So, but then to some degree, my two daughters, they know a lot of the children with Cohen, and then they came back. Actually, they still remember each other, and then they get a lot of hugs from the children too. So this is to some degree the two daughters. They actually also inspire with they want to help those children when they're young. They came to our clinic volunteer, but they want to they actually my two daughters know Alan very well, and I think that the many other children too. So to some degree they trust medicine as a career. Part of the reason they want to help those children, they know. So this is my family notes, small touching here. And then today I want to cover a few topics. This is mostly based on the list of the questions families have about the Cohen syndrome. They want some answer. And then I come up, this is my last minute preparation. I actually prepared most of the information this week. So this hopefully, I hope that is covering most of the question. So this is 5 areas I will be talking about. The first one is genetics of Cohen syndrome and the genetic testing. And then the second one is about nutrition. The third one we talked about at last gathering, but there was people ask this again. So I'm going to repeat a little bit what we talked about last year, last meeting 2 years ago. And then also the education and ongoing research. So the first I want to start about Cohen syndrome genetics and genetic testing. So we all know Cohen syndrome is autosomal recessive disorder. By the way, this is a beautiful picture. It's all they all come for the Cohen syndrome gathering in the past. I have permission to use those pictures from the parents. So this is actually, I'm assuming that some of the parents may be in this meeting. They're lovely, they're beautiful picture. I really enjoy every time when we talk about Cohen syndrome. I always use some of the children's picture. So this, let me just maybe start by some basic information. Cell. This is what you all learn. We all learn in the middle high school. biology class. This is a cell. There's a nuclear. So this is a cell we see in the picture. And then in the middle of the cell, you see this is the nuclear. And then in the nuclear, what do we see? You know, if we use the electron microscope, it is a chromosome. Chromosome, you have P and a Q, and then what is made up is what we call the DNA. Everybody know here. So this is the DNA, you know, with much detailed information. So the consonant related gene is called the VPS13B, and then it is you know, this amplify for the exactly the gene you know, this in the chromosome 8. And then, you know, when the children are born, they took the DNA from both dad and mom, and then have their own DNA. So next slide, I want to show you the gene. This is a gene of the VPS13B gene. So this is with 62 exons. One thing always keep in mind, you know, for the genetic testing, also for gene therapy consideration, this gene is huge. VPS13B is a big gene, so that really you know, that make the gene therapy challenge to some degree, and also make the genetic testing very complicated. So then I'm going to talk a little bit this you know, the exactly how the consonant inherited. Maybe start by you know, sharing this slide about the inheritance pattern. So in general, when the dad and mom marry each other, then when they have children, you know, they pass along their DNA to next generation. As you can see, this slide, you know, this is the dad, this is the mom, and then we label this chromosome as 1, 2, 3, 4, and you can see. The first child get the 1 from dad and 3 from mom. And second child get the 1 from dad and then 4 from mom. So if we go on, you can see the third child get a 2 from dad and then 3 from mom. And so we can go on to see the number 4 is get a 2 from dad and 4 from mom. As a result of that, you know, there's each child get something from dad, something from mom, and half from dad, half from mom. So that's the reason all the children resemble their parents. You know, they inherit DNA, they had DNA from their parents. Then there's a disease. You know, when there is a defect, you know, for example, this particular one. So we use red, you know, indicating person has a disease. So this particular one we talk about is actually we only need one defect to cause disease. So those what we call the autosome dominant. So this particular disease actually does not apply to the Cohen syndrome because Cohen syndrome is autosomal recessive. This is something I'm going to share with you next slide. So in the Cohen syndrome, both parents they have to be carrier. As you see, when we again we use this red dot indicating the defect, DNA mutation or change. Then when we, you know, the two carrier have children, you see, this red dot can go to potentially go to each child. When this first child get the balls, red dot, and then he get a 1 and 3, the balls with red dots. But the other children, they either get a red dot or no red dot. So you only get a double dose balls defect, then you would have a disease. So all other children, they are normal. They could be carrier. It could be perfectly normal, not carrier. So that's actually what we call the autosomal recessive. And then the chance to have children with Cohen syndrome is 25%. So that is a typical autosomal recessive that how the disease is inherited. And then go back to another question: if the autosomal recessive, if one is a carrier, for example, this slide, dad is carrier, mom is normal, is not a carrier, then all the children would not have a disease. So that's another notes we could write down. Yeah. Let's see. Then we're gonna talk a little bit, what is a unique part of this, to know all this. I think 2 things that we always keep in mind. One is the term we use is a heterogeneity. Those mutation in the constant, keep in mind that the gene is so big, and the mutation could happen throughout the gene. So the chance is, there's what we often call is the private mutation. So mutation only see in one or a few cases, very, very rare. And then sometimes the gene say, well, this is only first time reported in the literature in your family. So that's hopefully explain why, because the gene is so big. And then there's a huge, heterogeneity on that. But meanwhile, we also see some founder effect, which is, we refer as a homogeneity. The mutation could happen in major mutational hotspot. So that's Finnish population, for example, and an Amish population. They're actually they have a founder effect. They all have the identical mutation. So that's just kind of information we talk about. And then the genetic testing is very complicated. It's interesting. Many years ago, we did a survey. Even with all the technology, we still have 1/3 of the family, their diagnosis with Cohen syndrome, the children. But then one of the gene, one of the mutation is identified, but another one is not identified. So that indicating how complicated the genetic testing in the Cohen syndrome. One of the reasons is the deletion, duplication of the DNA is very common with a very high frequency. This is one slide that shows the publication published 10, 15 years ago. They shows a lot of deletion and duplication in the Cohen syndrome patients. That's really make the things very complicated. At least 2 families came to our clinic from other state. They did a lot of work with doctors, with lab, but they only found the one variant. Another just cannot find it. So actually, we work with them, with the families. I think one family, I knew she's actually online. We found the deletion which is not detectable with the conventional method. So we actually found that other family, I don't know if it's online or not today, this particular family has a homozygous, but then parents have completely different ethnic origin. So we just didn't believe this child had homozygous. Actually, the child we saw a couple of years ago, we actually did the further research. We identified was also related to the deletion mom has. So that was actually just accomplished last year, which is very, very rare. So that's the illustrate the challenge to diagnose Cohen, particularly the conformed Cohen. Other term you might hear is called the de novo mutation. That means it's not the variant is not inherited from the parents. It happened, at least one variant happened just in this child. So this is something we saw too. Sometimes can be confusing. And then the other term you might hear is a variant. It's called VUS. It's a variant of the unknown significance. So this is become very tricky because the doctor, after you spend $1 million, you spend $1 million do all this DNA testing, and then you still don't know, the answer because you run into 2 VUS variant mutation. We don't call the mutation, we call the variant because we don't know if it's meaningful. Then we still cannot decide if the child has Cohen or not. I know that 3-4 years ago, we had one patient travel from East Coast. I don't want to say which state, but the child was tested. They did the whole genome sequence. Then they found 2 VUS. So the doctor still cannot decide. Genetics cannot decide this is Cohen or not. They traveled to 3 major medical centers. I think they saw 3 genetics, but nobody could know for sure this is this child has Cohen or not. So they end up actually come to our clinic. Of course, in the waiting room, my receptionist still come to me and say, well, your patient is here, but I know he does not have Cohen syndrome. We saw enough. I think that our receptionist could make a diagnosis easily. So, that's come down to idea, sometimes you spend so much time, we spend so much time, money to figure out what is, but then clinical skill, expertise is still sometimes helpful to make a diagnosis. So this is our lab. We have a very state-of-the-art lab. That also help us to make a clinical decision as we work with the lab very closely to analyze the data, ourselves. So I'm going to move on. I know this is a very complicated genetic testing part. I don't want to go much further, but it probably will be more helpful individually if we have more questions. So I'm going to just go ahead and move on to next topic is nutrition. So we have at least 2 questions on this, how to address it. I think that one of the things we really need to keep in mind is Cohen syndrome, the children, they are different. They have shorter statures. They might have failure to thrive during the early stage of their life. But when they grow up, they rarely have obesity. So we need to keep those history, natural clinical course in mind. When the children are young, as a pediatrician, we keep the nutrition balanced. We treat them, with a good nutrition when they are behind for their weight. I generally tell the parents don't overly concern. You know, I have one family come to our clinic from other state with the feeding tube. So I encourage parents, and also I talk with the physician, manage these patients, consider take the feeding tube off. They can, I mean, when they are on the feeding tube, they lost the oral skill, and then I wouldn't put the feeding tube just because they are underweight when they're young. As long as we keep the good balanced nutrition, they are healthy. I mean, you do all this nutrition study, all the Cohen syndrome children, they are underweight, but they are healthy, and there's no nutrition deficiency. It's part of their disease. So this is something we need to continue advocate about this, you know, to educate the physician about this. So this is the issue we talk about during the early stage when they're young. When they grow up, when they reach to teenage or preteen, then they might have obesity. So this is a time we need to really think, you know, how to get their weight under control. We do use certain medication, you know, that you know, help them for the weight gain. I mean, it's basically to some degree the side effect of the medication we use to control their appetites, and you know, it has been helpful. So I would say here is a proactive, you know, trying to really work hard before they reach to the you know, overlay too much obesity. You know, they do. We do have 2 or 3 children end up on the wheelchair because of overweight. You know, I can tell you why. You know, 2 or 3 things combination. They do have low muscle tone, and then they also have a flexible joint. The joints are relatively weak. When they put a lot of weight on, then they start to have you know, leg, you know, the knee, and also ankle. The joint could have problem, and then chronically tired, and then they end up in wheelchair. Well, number one, we need to really work hard to prevent this happening. But if they did happen, you know, we need to get them, you know, I think get them out. One of the things is don't give up. I have one parents, they came to me after 6 months on wheelchair. They said, well, he will never get out from wheelchair. I tell them, you know, don't give up. Don't give up. But you know, they will get out. They will get the, you know, this particular child with Cohen syndrome. He was on his 20s, and after 2 years on wheelchair, he's working. You know, I think the most important part for that is actually get a weight under control, get them lost weight, and do the physical therapy. So we actually, at least 2 children, they end up on wheelchair for months. Then we get up, and they get up, and then that's very encouraging. So the message I can give everyone here is prevent this happen. But if this did happen, it do happen, don't give up. So the next things I want to talk a little bit is actually a topic I talked already last meeting is airway challenge. You know, this Cohen syndrome, the children, adult, they're different. They have very difficult airway. You know, it is challenge. You know, the people kind of frequently, physician, the dentist frequently overlook this. You know, but then that is our rule. Trying to really keep that in mind. Also remind the health professional. It is a challenge. We need to be careful, and you know, this is the list of the reason why the Cohen syndrome patients they have a very difficult challenge airway, because they are intellectually they have intellectual disability. They not always cooperate. Then you know, when we have procedure, when when we put them under the sedation, this is always could be issue to the physical exam, and then they have small head, short stature, trunk obesity, low muscle tone, and small jaw, and very narrow high arch palate. And then they also have very prominent central in the teeth. And then they have neutropenia, they have frequent infection. All these together, each one of them, and a lot of the anesthesiologists know maybe 2 or 3 of them, they will be already challenging for them to manage the airway when they put the intubation. But then the constant patients, they have all of these, most of them. So this is why we face the challenges. This is actually, you see when they open mouth, you see what they look like. And then, normal people is actually, when open mouth, you can see very clearly. But with constant, when you ask them open mouth, what you see is on the right side of the slide. You really cannot see well the inside of the mouth. And then this is not something we see, but the anesthesiology, when they do the intubation, they actually see that vocal cord, and then the vocal cord is not so visible, and then it's hard to insert the intubation tube if you don't see vocal cord well. So that's all the reason it's hard to manage it. So the recommendation is keep always always keep that in mind. Always just kind of remind that a lot of education and effort we need to put on, and then when they need a procedure, if they need a sedation, we need a highly trained profession to perform the procedure, and all stand by. If there is something happen, they can intubate professional. They're more ready, and then we need to educate the health profession. So this is actually, I was invited to contribute to the OrphanAnesthesia. This is actually website for anesthesiologists. So we trying to develop the online resource on Cohen syndrome for the health profession. This is actually especially designed for the sedation for anesthesiologist website. So we're working with them to include the Cohen syndrome to be part of this that resource. And then I'm gonna quickly, I know I don't want to talk too long because there's other very interesting talk you would like to hear. This is I want to just very quickly go over education effort. This is we always feel strongly it's important to get the word out and to educate a health professional physician what is a Cohen syndrome, what we could do for those children. And then we have this gene review. This is actually online resource we help with for the geneticists to learn what is Cohen syndrome, and then also we are trying to publish and then continue publish. I know this is a previous publication. Let's see, and then we have 2 at least I know of 2 or 3 more publications regarding Cohen syndrome. It's actually our clinic. I personally engage, and then hopefully it will be published next 3-6 months. To increase awareness, to advance the research. So this is a phase 2 gene. We also help with the enter this, and this is the NIH website. Genetic home reference. We also help with create this website and then to create for the entry. This is node. We also help them to review this entry for the node. And then this is an OrphanNet. I also work with them to get this words out and to make sure the information we provide is accurate. And this is a European website. And then the human disease gene, that's entry. We also help them to build this website for the Cohen. And then I just say another website resource for sedation for the anesthesiologist. We also it's coming. It's coming. So this is an education effort. And then I'm going to maybe just last couple slides talk about the ongoing research. This is something I'm excited about. I share this with other families and also share this with Ashley too. For years, when we started our clinic, the consultant, we did a lot of the time investment, to really learn, study, doing research. And then, the clinic getting very busy. I was pulled away with a little bit different direction. And then just last 2 years ago, we hired a generalist join us. So we really, I think that, for when we move forward next 10, 20 years, what else I really should focus. Of course, the Cohen syndrome is number one of my priority. And then I said, well, I really need just trying to really do some research. So this is actually something we are passionate at it. I do think that, this is the clinic here set up doing the research. We talk about over 100 patients. We set up very well set up for doing the natural history study. And then also we have see the patients every week. I don't recall any week last 20 years I have not seen Cohen syndrome patients. So this is a daily work we do. So we really want to do some natural history study. That's actually is not as fast as we like, but the funding always an issue. But we'll work on it. We'll continue to work on this. And then I discussed this with Ashley, and then she has been very supportive. And then we tried a couple times with other foundation. We didn't get the money, but then we're not giving up. People, our clinic here, my staff know I'm not giving up on anything if I believe it. So and then another two topic is glycosylation and then biomarker. This is something I would like to let my colleague Dr. He will be talking about. Maybe I can just tell you a little bit story. This actually happened last year. And then just through this story, I'm going to introduce our next speaker. Last year, it's almost about a year ago, I got a call from person I respect very well